Hi everyone, a blessed day to all of you. Praying that all of you are safe and doing well together with your families and loved ones. So this presentation is a continuation of our topic last week about the care of patients with problems in the immune system. Okay, before we proceed with our topic, let me first share to you this disclaimer slide. Please note, no copyright infringement is intended and I do not own or claim any images, designs, and any of the original information stated and used in this video. And this is for educational purposes only. If any content owners would like to dispute this, I will not hesitate to immediately remove the said content. If you happen to find your art or images in the video, please let me know and I will be glad to credit you. Here is my email, aubrey.dairit@cghc.edu.ph. So this is the outline of our presentation. We'll discuss first the pathophysiology, the clinical manifestation, and nursing management of patients with primary immune deficiency disorders or PIDD, the mode of transmission, and the nursing management. Majority of the primary immune deficiency diseases are diagnosed in infancy, with a male to female ratio of 5:1. However, some PIDDs are not diagnosed until adolescence or early adulthood, when the gender distribution equalizes. So diagnosis at this stage are frequently confounded by frequent use of antibiotics that usually mask the symptoms. On occasion, adults present with clinical episodes of infectious diseases that are beyond the scope of normal immunocompetence. For example, infections that are unusually persistent, recurrent, or resistant to treatment, and those involving unexpected dissemination of disease or atypical pathogen. Let's talk about the pathophysiology of PIDs. In the United States, there are more than 200 different forms of PIDs, affecting about 500,000 people. More than 270 different genes are associated with PIDs that are recognized by the International Union of Immunological Societies, according to Hernandez Trujillo et al. In 2015. These rare genetic diseases prevent the body from developing normal immune responses. There is an abnormal immune response that results in a complex group of disorders with a wide array of clinical presentations. So, many present during the first year of life and may be chronic, debilitating, and costly. So, the major signs and symptoms of this PIDD includes multiple infection despite aggressive treatment, or there would be infections with unusual or opportunistic organisms. There will be failure to thrive or poor growth and a positive family history. Patient with PIDD may have B-cell deficiency, wherein they may have a gamma globulinemia or hypogamma globulinemia. A gamma globulinemia refers to the absence of plasma cells leading to complete absence of antibodies. This is also called Bruton's disease, wherein the B cells in the peripheral blood is low or absent. An infant born with this type of disorder suffers from severe infection soon after birth, while the hypogammaglobulinemia, which is also called as CVID or common variable immunodeficiency, wherein it could have one Ig that is affected, or also called pan-hypogammaglobulinemia, wherein there is a general lack of immunoglobulins. This is most common primary immunodeficiency in adults. The diagnosis includes quantitative immunoglobulins. This is to determine the amount of immunoglobulin. The treatment could involve IV, IG, or antibacterial and genetic counseling. Patient with PITD may also have T-cell deficiency, or known as DiGeorge syndrome, which is also known as thymic hypoplasia, wherein the thymus gland fails to develop normally during embryogenesis. Okay, it usually manifests in the neonatal period, and a child born with this disorder suffers from hypoparathyroidism that results to hypocalcemia or cleft palate and possible renal abnormalities. They are susceptible to all types of infection. For the clinical manifestations, it includes hypoparathyroidism, hypocalcemia, congenital heart disease, renal abnormalities, and susceptibility to infection. For the diagnosis, the patient may have peripheral blood lymphocyte count, and for the treatment, particularly for the patient with symptoms, they could have calcium supplements, antibacterial such as miconazole, clotrimazole, ketoconazole, and antifungal such as your amphotericin B. Clinical manifestations includes ataxia and telangiectasia. So, ataxia is a term used for a group of disorders that usually affect the coordination, balance, and speech, and any part of the body can be affected. But people with ataxia often have difficulties with balance and walking, while telangiectasia are small, widened blood vessels on the skin. They are usually harmless but may be associated with several diseases. So it may have viral, fungal, bacterial, and protozoal infection. So the treatment includes IVIG, thymus transplant, antibacterial, and antifungal, also bone marrow transplantation. Patient with both B and T cell deficiency may have ataxia telangiectasia. Again, as mentioned in the previous slide, ataxia, there would be loss of muscle coordination, so there would be problem with the balance. Telangiectasia, there could be a vascular lesions caused by dilated blood vessels with immune deficiency. And then the manifestations becomes more severe in increasing age. It occurs in the first 4 years of life, and it can survive till the fifth decade. So the manifestation usually starts by second decade of life. The severe combined immunodeficiency disease, or SCID, both T cells and the B cells are missing. Both cellular and humoral deficiency is affected. In the first 3 months of life, it could already be present. While Wiskott-Aldrich syndrome is a variation of SCID but more of an inherited immunodeficiency. So again, as a summary of our etiology and pathophysiology of your PIDD, or your primary immune deficiency disease, it includes B cell deficiency, T cell deficiency, and a combined B and T cell deficiency. It also involves genes, and this is common in infant and young children. So there could be inborn errors of immune function which predisposes people to severe forms of infection. For the assessment and diagnostic findings, it is crucial to carefully assess the family history, because there is often a considerable delay between the onset of the symptom and the time of diagnosis of PIDD. This is because of the genetic origins of the PIDD. So, laboratory tests are also used to identify antibody deficiencies, cellular or T cell defects, neutrophil disorders, and complement deficiencies. A complete blood count with manual differential should always be analyzed first to detect lymphopenia and to check for serum IV levels. So lymphopenia may indicate an immunologic abnormality. The serum IG levels, such as your IgG, IgM, and IgA, and antibody responses to vaccines should also be assessed to detect a humoral immune defect. Age-matched normal ranges need to be used since antibody levels change as the person ages. So according to a study of Younger et al. In 2015, live vaccines are contraindicated in patients with antibody deficiency disorders. The patient is incapable of generating antibodies, and the live substance in the vaccine can cause disease. Therefore, family planning should be addressed in terms of future pregnancies. In some situations, prenatal in utero testing of a fetus can determine whether the infant will be affected. Pharmacologic treatment depends upon the type and severity of presenting infection and the particular PIDD diagnosis. So, a prophylactic drug treatment prevents some bacterial and fungal infections, but it must be used with caution because it has been implicated in the emergence of resistant organisms. So the choices for empiric therapy could include combination regimens and monotherapy. For specific choices depends on local factors. For the nursing management, since our patient is prone to severe infection, therefore nursing care must be meticulous. So it's important to do hand hygiene and infection control prevention, and to continue monitoring of patient's condition This is very critical, so early signs of impending infection may be detected and treated before they seriously compromise the patients. So the patients and the caregivers in the home are taught how to administer medications, including regular IG replacement therapy if prescribed. So instruction is provided to the patient, including the family, about how to administer the therapy at home. So the nurses must provide education and support for the patient and family. Now moving on to secondary immunodeficiency disorders. So, the clinical manifestations includes the following. The client presents with classic sign of immunosuppression and is unable to mount an immune defense. So there is a wide range of presentations reflect the client's current immune status, and there would be overwhelming infection and increased response to opportunistic organisms. For the assessment, it is really important to monitor the client's WBC or the white blood cell count and look for ANC or absolute neutrophil count to know if there is already a presence of infection. And then it is important to identify underlying disorder, if there is any other comorbidities, and determine client's current medical status as it applies to the immune response. So it is also important to monitor the client's nutritional status and determine the hydration level. For therapeutic management, it is important to treat and stabilize the client's underlying disease process because this may also affect the condition of your patient. So institute neutropenic precautions if warranted to prevent further risks for infection and maintain protective isolation as warranted. So as a nurse, it is important to identify potential infection sources and stabilize baseline immune level. You have to collaborate with dietitian in order to support immune functions and maintain integrity of body systems. Now moving on to planning and implementation. So it is important to maintain protective isolation as warranted. You have to monitor ANC or absolute neutrophil count, blood work, and pending cultures. You also have to assist the client during times of stress and isolation due to chronic nature of disease process. And you have to collaborate with healthcare team members to support the client's activities of daily living and lifestyle changes during this hospitalization and after discharge. For medication therapy, So, antimicrobial therapies provide support against infectious processes if this is usually prescribed by the doctor. Colony-stimulating factors usually boost immune response. Medications specific to underlying disease process are used to maintain the immune balance. Moving on to client education. It is important to provide information about the chronic nature of the disease process. This is to help the client as well as the family members to cope with the disease process. And then, establish a collaborative network for the client to maintain contact during the discharge process for continuous care. And promote client self-monitoring of condition to identify potential health problems sooner. So that ends our topic for this week. So just be ready for our next topic about particular immune disorders such as your HIV and allergic rhinitis and etc. So God bless everyone and thank you very much.